beautiful city to talk about orthopedic trauma. And I'm going to talk a little bit about reduction techniques for trochanteric fractures. So how many, I'm sure everyone in this room has this conversation nearly every day. Hey, whoa, geez, can I ask a favor? Yeah, sure. Well, how would you fix this? Oh, nail. Okay, I'll nail it. I mean, well, it's fixed, isn't it? You know, you all are recognizing the problem, right? It's fixed, but it's not reduced. This is, I think, too common of a scenario for us. It's all we see is a fracture and you want to fix it. But this is not the right approach. I want to change the thinking around. I want to do what Joel Madden noticed. He says surgeons think first on how to fix, but what you should really think before you start to fix is how you are going to reduce. That's the theme of this talk. So the goals of treatment for trochanteric fractures is to restore function, immediate weight bearing of your patient, reduce pain, fracture union, and to avoid reoperation. And I submit to you that those goals can be most easily achieved with an accurate, stable reduction. The question then you should ask yourself is, okay, what is an accurate, stable reduction? I'm going to tell you three major features of this. One is restoration of the neck shaft angle and restoration of hip offset in addition to proper sagittal alignment. Why is this so important? Because if you don't restore the offset properly or you leave your patient too short, physiologic changes can happen. They have increased oxygen consumption with weight bearing and mobilization, and they can lose their abduction strength by losing their femoral offset and lever arm. Bone contact is the second important feature of an accurate, stable reduction. What's important about bone contact, as we saw in some of Mark's cases, is load sharing is very important to add stability to your construct, to offload or take the stresses from your implants. This is especially important in osteopenic bone or in bone with some comminution that's involved as well. Bone contact and stability will also decrease your patient's pain, and it will also enhance fracture healing. The third point I want to talk about, I want you to pay attention to when you do reductions, is this anterior medial cortical reduction, or even an over-reduction might be preferable. And Mark showed that on one of his cases as well. When that medial cortical bone is not well reduced or obtaining contact, over-shortening can occur. The Japanese have studied this and have showed this very well. So in cases where there is intramedullary reduction, or the proximal fragment is inside the bone, you get too much shortening. And the reason is simply you cannot share the load with the bone, and so the bone settles and collapses. And so this is just a case here. You can see this intramedullary reduction, and after a month or so, there's over 1 centimeter of shortening and increased varus. So it's not a complete failure. The nail has somewhat helped you here. If this was a sliding device, you would be in big trouble with this reduction. You can easily manipulate this and try and improve that reduction by simply externally rotating the femur, disincarcerating that fragment or that spike, applying some new traction, and then re-internally rotate, and many times this will reline that bone up. If not, you can consider percutaneous methods with simple instruments such as elevators or even a custom implant such as this to just tie or lever that cortical bone back into contact, so as you can see in these drawings here. So that's a feature that's not totally appreciated, I think, by most of us in many cases. So the next thing is to assess reduction, and how do you do that? It really depends on your imaging, right? You need to know and have a standardized set of images that you get during operation to assess your reductions. You need a true AP, and what the AO has come up with, what they think is a true AP, is one with a smooth medial calcar, profile the lesser trochanter with a normal profile of the greater trochanter. And I would like to add, when you see that little dip of the piriformis fossa, you have a good lateral that you're looking at. And then the lateral view an AP view. A true lateral view should be one that's about 180 degrees in line, the neck and shaft. So 170 to 190, somewhere in there, with very smooth confluences of the femoral neck and the lateral anterior and posterior aspects of the proximal segment. This is what you want to look for a lateral view. This is an example of a poor x-ray. You cannot assess this lateral very well, and instead of rotating the leg, which could malreduce the fracture, you simply want to rotate the C-arm up until you get that lateral view. And now you can really assess your reduction properly and do your nailing safely. In terms of reduction techniques, I like to start with simples, right? You start at the base of this pyramid with indirect simple traction. And as you become more invasive, you move up this pyramid in terms of invasiveness. And so you would then start to use more invasive approaches to obtain the reduction. But the vast majority of cases can be achieved with an indirect closed reduction. This requires some form of traction. And in my hands and in my hospital, in my cases, I use a traction table. I use the one you see on your left, the scissoring technique. But you can use a well leg holder if that works for you. You can use traction off the end of a table on a flat top, or you can use a distractor. All of these provide the same feature, and that is controlled traction. Here's a case. This is a case of one of my colleagues from Switzerland, Christoph Sommer. It's a simple 31A1 pattern. Starts to put some traction on it. It's not ready yet. Look, it's that classic intramedullary reduction, and it's still in varus. So dials it in a little bit more, maybe rotates and checks that a little bit and applies more traction, and we're still almost there. And then finally he achieves that reduction. This is what it should look like. This femur is now ready for nailing. As you can see here, those fragments are now in the right position. And so there's the lateral. Notice the lateral is appropriate in that good imaging. And so he goes on to nail this uncomplicatedly, and he compares it to the opposite side and has restored the proper head-neck offset for a good nailing procedure. Here's a 77-year-old lady. She fell. She has this fracture here. So we put her on the fracture table and we apply traction. And despite what we do with the fracture table, we can't get her out of this retroverted position. Looks pretty good on the AP, but we're not right on the lateral. So if the traction's not working, you need to move up the ladder. You need to move up the pyramid. And so the next step is to do a percutaneous approach. Of course, you could try and push on this with your hands or a mallet outside the skin, but that's going to be in the way of your imaging likely, and or your hands are now in the x-ray beam. So use some type of percutaneous instrument. It is not a sin to do that. And so simply, you can use a ball spike pusher and many other type of devices. This is just an example how a simple small stab incision in a safe location and a little bit of percutaneous reduction will assist on both AP and lateral views to give you that proper reduction and a proper nailing. Here's another case. This is an 83-year-old female with a more comminuted trochanteric fracture, as you can see here. Lots of fractures going on. We put her on the table. We apply some traction, longitudinal traction, and again, looks good on the AP. But the lateral, it's just not ready for nailing yet. So we can try some percutaneous methods. We can use the ball spike pusher and other things. But what I find very helpful in many of these cases is percutaneous wire, cerclage wire. And before you all go, oh, cerclage, it's okay. It's okay. It's safe to use if you do it properly, and it's incredibly powerful. So I like to use this technique in many of these cases because it gets my clamps and things out of the way of my nailing instruments. But a simply applied percutaneous wire can very nicely line this fracture up on AP and lateral views, and again, give you that proper anatomy and anatomic alignment and a good nailing. Here's a case, again, from my colleague in Switzerland. This case here just shows it's not quite ready for nailing. He recognized that this large posterior medial fragment is very important for stability of the fracture. And remember, one of our goals was bone contact. So using percutaneous cerclage wire technique, he is able to draw this fragment in to help support the fixation. I don't know if you have access to this device. If you don't, you can simply use regular cable wire passers. But this is a really cool device that you can do very percutaneously, as you see here. It's a two-piece device. It goes in through a very small incision. You can pass a small 18-gauge wire, and it comes out in the two pieces with a small incision. You can tighten it with the power, cut it, and as you see here, he recreates a tube, and now he can do an uncomplicated nailing with a well-reconstructed proximal femur with very little dissection. Here's a case, again, another percutaneous technique is a clamp. And I like to use the collinear clamp, or you can sometimes do this with a bone hook. But the clamp doesn't get tired of holding. So these A3 patterns with slight obliquity to them, this is a classic example. This can easily be clamped and then nailed adequately. Here's a 79-year-old female. Again, very comminuted trochanteric fracture. You can see here on all these fracture lines, broken greater trochanter, lesser trochanter's off, calcar is broken. Again, we go through the sequence. We put them on the fracture table, we apply traction. We look at our AP and lateral views. Decent on the AP, lateral is usually not right in many of these cases, as you can see there. So you can use other type of clamps. You can use a serrated tooth clamp to move the shaft where it needs to go, or again, the collinear clamp. Ask yourself, are there any other options? Yeah, you can use the cerclage wire if you need to. Again, the fracture can be treated in these ways very simply. I didn't have a follow-up x-ray, but she had a CT of her pelvis for another reason, and I just happened to see these images, and she went on to heal fine in good position. Here's a 90-year-old female, as you can see here. Again, highly comminuted, looks very good on the AP, not quite right on the lateral yet. Sometimes you have to use combinations. You can't just run it up the middle every time. You have to maybe do a handoff or a fake this way or a reverse or something, or use all of them together. So this is a pointed clamp with a cerclage wire. Then I use a ball pusher to help contain the lateral wall during the implantation, the reaming and the implantation of the nail. So sometimes these things need to be used in combination. No single one technique may be efficient or may be successful. Sometimes you need to push, pull, or rotate. So this is a chance to use a Chance pin, something fairly stout if you have one of these A3 type fractures, especially in younger patients with large deforming forces. This is a nice technique to help get that fracture or fragment out of varus. The ball spike can be used to take it out of flexion. And then if you're really battling your fixation or your temporary or maintaining the reduction, I do not hesitate sometimes to place a stout K-wire through the anterior head and neck and even into the lower aspect of the acetabulum. This will help assist your maintaining reduction. And in this case, I'd be critical to say this is still in little varus, and I like Mark's idea of taking a lateral clamp. He showed you a nice use of a plate inferiorly, but this has a ledge, and you can probably clamp this and improve this reduction even better if you wanted to. And so this holds this in place while you nail it. Here's another case, starting to get more complex. You have this multi-fragmented trochanteric fracture, as you can see here. We try our closed reduction with traction and even a cerclage wire technique, which didn't work for whatever reason, so we had to bail on that. And so we had to go to an open approach. This was incarcerated, something was blocking our reduction, and so now we move up the ladder to a direct open approach. So I usually have a set of clamps available to me that I can use for various reasons and various positions. So what we do is we obtain reduction with the traction again, and then we do a direct reduction using a serrated clamp on the main shaft to help manipulate that into position, and then can hold it there with a Weber clamp or even a cerclage wire. So this would be an example where this clamp here would take the segment, move it into position, and then you can line up the fracture, hold it there with your devices, and then place the nail. What I'm showing here is another technique that I've used when I'm very concerned about blowing out the lateral wall of the trochanter with my nail entry point. So I do three things to help prevent what I call trochanteric escape. I apply this this little buttress plate on the lateral cortex with unicortical screws. I'll do a very medial or a medial entry point, and I may even clamp part of the fracture if I can get it on there. And then the third thing I can use, if you have this available to you, it's very effective. It's called the hollow reamer, and it's a coring reamer, and it works like this. So if you have a solid opening reamer or a big awl and you stick it right through the fracture, what do? You blow it apart, you separate the fracture, and you tilt it into varus. With this hollow reamer concept, you just core out the hole, you don't displace the fracture, and the nail can go in nicely. If you don't have that device, don't worry about it. I just showed you some ways you can avoid blowing out the lateral wall. with an auxiliary plate on the lateral cortex. Sometimes you need to be really creative. So I have my partner had a patient who was close to getting a total hip, and she had this comminuted trochanteric fracture, but she didn't want the hip now for whatever reason. But so she wanted to have this thing fixed first and have it heal. So he was very cognizant of the fact that he wanted to maintain the anatomy of the proximal femur as normal as possible so that her total hip would be uncomplicated. And so in his mind, he was worried about the lateral wall, not only deforming during nail entry, but even later on during rehab. So he came up with this interesting solution, where as you can see here, he reduces it and then lays these two wires down. He determines his path for a 130-degree angle device, and then he uses the lateral buttress plate from the DHS set to put it on the lateral cortex, and then he secures it to the bone, and now this is going to be a substituted lateral cortex, which is going to contain the lateral aspect of the greater trochanter. And because he knew his path was set by the first 130-degree guide, he was able now to go ahead and place a cephalomedullary nail through the hole in the buttress plate, and now he has this construct which will not collapse or will not break into fragments or change its anatomy. The final tip I wanted to talk to you about is this idea of provisional plating prior to nailing. If you have comminuted fractures or transverse fractures, they're very hard to hold with clamps and wires, right? So well-placed small reduction plates can help you in this fashion to help you remove the clamps that are in the way of your nailing instruments. So this is something to keep in mind. There's a paper in Journal of Orthopedic Trauma on this technique. And then Mark mentioned this concept of hybrid fixation. And although this is still being sorted out and where its role may be in trochanteric fractures, there actually was a study that looked at the addition of an anterolateral plate to a nailing construct. They found that it significantly decreased shear and interfragmentary motion of those interfragmentary pieces. And they recommended to consider this technique for highly unstable fractures. So a couple of just reminder tips before I go. One is you should think about starting more medial to the greater trochanter than you normally do. You need to obtain your reduction before reaming and placement of your implant. Once the implant is in place, you cannot force it back with an instrument, and if you try to do it with a collinear clamp, you're going to tilt it into varus or create a deformity. The other thing I like to use sometimes, to get my clamps out of my way with a simple pattern or so, I will place a wire anteriorly to hold that fracture reduced out of the way of my nail so that I can nail it. This is a little bit of an older article now, but if you're also looking for more tips on intertrochanteric nailing, this is a really nice, simple paper with some good ideas of how to get more success with your technique. So, in summary, an accurate, stable, load-sharing reduction is important for successful nailing of trochanteric fractures because it allows us to get bone contact and stability, which allows us weight bearing immediately and increases our chances of healing. There's a progressive invasiveness that you need to undertake to reduce these fractures sometimes. Start with the closed techniques and move up the ladder. And remember to think about reduction before thinking about how to fix, okay? So thank you very much for your attention.